Blood transfusions save lives, but they also set up for immune system drama. The USMLE loves to ask which reaction, how fast it happens, and what immune mechanism is behind it. If you master the timing and pathophysiology, you can nail every transfusion questions. Let's start with the most common and least dangerous, the allergic reaction. This is a type 1 hypersensitivity triggered by plasma proteins in the donor blood. The patient may develop urticaria, itching, flushing, and wheezing, usually within minutes to an hour of transfusion. It is mediated by IgE and mast cell degranulation. If the patient has IgA deficiency, the reaction can escalate to anaphylaxis with hypotension, shock, and respiratory distress. Always ask about prior transfusion history in these cases. Next is acute hemolytic transfusion reactions, a type 2 hypersensitivity reaction. Here, preformed anti-ABO antibodies in the recipient's plasma bind to donor RBCs, and that triggers complement activation and intravascular hemolysis. The classical signs here: fever, chills, back pain, hemoglobinuria, and renal failure, usually during or shortly after the transfusion. Now on to febrile non-hemolytic reactions. These are caused by cytokines and not antibodies. Here is what happens. Donor leukocytes releases cytokines during the storage, and when the blood is transfused, the recipient reacts with fever and chills. It is benign and self-limited but can be scary. Giving leuko-reduced blood helps prevent it. And then we have TRALI, that is transfusion-related acute lung injury. It is one of the most severe reactions caused by donor anti-leukocyte antibodies that activate the neutrophils in the recipient's lung. This leads to non-cardiogenic pulmonary edema. And this condition presents with respiratory distress, hypoxia, and bilateral pulmonary infiltrates within 6 hours of transfusion. It's not volume overload, it's an inflammation in the lungs. Finally, there is the delayed hemolytic transfusion reaction, a type 2 hypersensitivity as well, but it occurs days to weeks after transfusion. This happens when the recipient was previously sensitized to minor antigens like Rh and now mounts a secondary immune response. RBC gets opsonized and removed by macrophages, resulting in extravascular hemolysis. Symptoms are usually mild, low-grade fever, jaundice, and even asymptomatic, but lab tests show new anemia and positive Coombs test. Now let's recap. Allergic or anaphylactic. Remember, type 1, IgE, immediate, and then also remember rashes, wheeze, and shock. Number 2, acute hemolytic. Type 2, ABO mismatch. Clinical features are fever, flank pain, hemoglobinuria. And then febrile non-hemolytic reaction. Cytokines from donor WBCs resulting in fever, chills, and important is no hemolysis. And then transfusion related acute lung injury. There is anti-leukocyte antibodies. Neutrophil mediated lung damage happens here. Delayed hemolytic reaction, which is type 2, and it occurs days later. Remember, extravascular hemolysis and mild symptoms will be there. Timing is your best friend in these questions. Combine the clock with the mechanism and you are done in seconds. You have officially wrapped up all the 18 chapters of immunology. The effort you have put in is massive and it's going to pay off. Let's carry this momentum into your next subject too. You are not just preparing, you are mastering medicine. This is Dr. Ram here from MedMadness signing off. See you next chapter. Thank you so much.